right, we're clicking. Continue. All right, so we, oh, somebody joined. All right, good afternoon. Thank you for joining us for our She Talks. We're going to give it just like one more minute so everybody can go ahead and get on. So I can see the numbers starting to tick up with people that are joining. So that's why I'm going to give it just a little bit of time, because we all know how technology works. Although I think it's really funny when technology screws up for speakers that are IT speakers or technology speakers. I feel what is it, vindicated when something messes up with their speeches or their events, because then it's like, whew, it's not just us. All right, just a couple more seconds. All right. Here. All right, so we will go ahead and get started. So welcome everybody. My name is Monica Lindstrom, and I am one of the board members for Arizona Foundation for Women. Today we have She Talks, and we're focusing on heart health for women. Little did you know that this is, I would like to say, a silent killer, in the sense that no one ever thinks of heart disease as being the #1 killer for women. And so we're going to talk a little bit about that. Now, our She Talks, this is a series of events that we host, and it's our way of educating the community and giving back so that people understand some very important issues that affect women here in Arizona that we don't always hear about, or we don't get enough information about. So our She Talks is a series that we like to focus on the she, that's the safety, health, and the economic empowerment of women here in Arizona, because we all know that we need help in all those areas, right? So She Talks focuses on the safety, health, and economic empowerment of women. See what we did there with the SHE? I love explaining that, it's fun. So normally, you know, pre-COVID, if you can remember that, we would have these events live, and we would invite people to come either to the library downtown or to our building here, or wherever we may be, so that we could experience this together. But when COVID hit, we realized that obviously people don't want to get together, or we couldn't get together. So we decided to go ahead and move this to an online platform with webinar, just like everything else out there. And we found that more people are actually able to enjoy this, and we do record it. So at the end, or if you're not able to stay for the whole time, please go ahead and go to our website, azfw.org, and you can finish watching the webinar. And please share it out on your social media, send it to your loved ones, your moms, your aunts, your best friends, your sisters, your cousins, and let them get this information, because it is so very important. So the mission of Arizona Foundation for Women is advancing the status of Arizona's women through research, advocacy, and philanthropy to ensure their safety, health, and economic empowerment. I remember the first time I met Misha, who's our CEO, I remember her saying that we wrap to she. That is the tagline that we use. We wrap the research, advocacy, and philanthropy to she, which is the safety, health, and economic empowerment. And that's always stuck with me. I think it's just such a cute little saying, but it works perfectly for what we do. And, you know, I like to listen to rap music, and I used to listen to rap music, so it resonates with me. So at AFW, we hear almost on a daily basis from both women and men, how can I get more involved? They contact us and say, oh, wow, I love this organization. How can I get more involved? Can I volunteer? Can I give money? Well, of course you can give money, right? But we do have many opportunities to become involved. You can become a member of AFW for as little as $10 a month. You connect your giving power with other like-minded Arizonans who are leading the fight, so every woman in Arizona can change what is possible for her. for her community and for future generations. So you might think, well, $10 a month isn't very much. Am I really helping anybody? Well, if you give $10 and let's say your aunt gives $10 and your best friend gives $10, now we have $30. And if that's $30 a month, then we're talking about, what, $360 a year. And that can go to help somebody with or with one of our many projects, because we grant out that money. So it is a wonderful way for you to put your power with others to make things better for women here in Arizona. We also have our She Partners program, where we collaborate with corporations throughout the valley. So if you're a company, if you're business, if you're a solo practitioner, right? Or if you work for a big company, if they have an affinity for women's groups, then go ahead and contact us and we can become She Partners and bring the wonderful information and the power to so many more. And then, of course, we have numerous volunteer opportunities. You can volunteer to be on one of our committees as we go through the year with our research, advocacy, and philanthropy, and our many events that we have, such as She Talks, and our annual event where we acknowledge some of the most incredible women out there that are making changes in the lives of Arizona women. So for all information on AFW, you can go ahead and visit our website. It's azfw.org. It talks all about how you can get involved. You can see our past webinars. You can look at our research report that we put out every 4 years that has an incredible amount of information. If you're part of another nonprofit, you might find some information there that you can use in your grant applications as well. All right, so let's really start talking about why we're here today. We're educating, right? We wrap to she, and one of those things is heart disease. And the term heart disease refers to several different types of heart conditions. And we have a doctor here who is extremely educated and familiar with all aspects of this. And if she's not, she said she would let me know if there was a question that was too hard or not her expertise. So she's going to lead us down this road of educating us on this silent killer, because it's not just a man's disease. It is a woman's disease, and it's the #1 killer of women. So to tell us more and to educate us on how important it is, today we have Dr. Camille Phuc, and she is just wonderful. I was talking to her beforehand, and she is so experienced. And as you can see with the information that we just pulled up, and if I can pull up my information, where did it go? It disappeared, the technology. There we go. Okay, so Dr. Camille Phuc is board certified in cardiovascular disease, echocardiography, and nuclear cardiology. I think I said that right. She completed her fellowship in cardiovascular disease at Rush University Medical Center in Chicago, Illinois, and her internal medicine residency at the University of California in Sacramento. She earned her doctorate of medicine and her undergraduate degree from Brown University in School of Medicine in Providence, Rhode Island, where of course she graduated with honors. And she said that she enjoys the snow. I personally think she's crazy, but she said she enjoys the snow. So Dr. Lay specializes in the diagnosis and management of cardiovascular diseases. And she's going to tell us what it means when she says cardiovascular diseases. Her focus is clinical cardiology with a passion and interest in women's health. So see how she fits right in with the mission of AFW. And most importantly, she believes in open and honest communication with patients, family members, and caregivers, and involving them in their care plan, which is so very important. And women are often involved in the care plans for their entire family. And so the open communication is key. So Dr. Lay, thank you so much for joining us today.
Thank you so much, Monica.
So tell us, talk to us about this silent killer. And I say a silent killer because we don't hear about it a lot. So tell us about heart health in women.
Sure, yes, definitely. So, as you mentioned, it's the leading cause of death in most of the developed country. And a lot of times we're seeing the rise of this in some of the resource limited countries as well. And, usually the signs and the symptoms of heart disease in women are a little bit different than men. There are some women with typical symptoms, but sometimes they have symptoms that are very different that would make it difficult for diagnosis. And there's also the culture of understanding and also be able to, among clinicians, to recognize that these are the symptoms of heart problems. Um, so today, I focus mostly on when we said heart disease, we're talking about, as you mentioned, Monica, many different types of heart problems. We have the coronary artery disease. That's when we're talking about heart attacks, etc. We have congestive heart failure when we're talking about weakened heart muscles, which can be independent of the coronary artery blockages. And then there's other kinds, the arrhythmias, the irregular heartbeats, the palpitations that people feel. So the field, obviously, of cardiology is so broad, but today, we will kind of focus mainly on the coronary artery disease, just because that is one of the most common issues and very commonly causing the mortality and the morbidity among everyone, especially in women.
So, Dr. Lay, when you talk about the coronary artery, I think that's what you just mentioned, right? Is
Yes.
this why we shouldn't eat all that butter and we shouldn't eat all those donuts and, all that kind of really yummy stuff?
Yeah, it's unfortunately the things that taste good may not be that good for you in the long run. Um, you know, we talked about different types of diets, and in the clinic, for me, talking to patients in general, a lot of the preventative measures are with diet and exercise. There's been studies about different kinds of diet. There's the vegan diet, Mediterranean type, the keto diet. Um, what we have, I think, from research among the cardiology and observational studies, we have found that Mediterranean diet tend to be better overall in terms of lowering the risk of heart attacks and strokes. And I think the main reason, and it is even better in terms of reduction than a vegan diet or a vegetarian diet, in the sense that a Mediterranean type of diet has a lot of omega-3, a lot of antioxidants, and not a lot of those, butter and the solid kind of fats at room temperature that we always talk about. It's more fresh vegetables, fresh fruits, fish, some nuts, and some of the healthy fats. So those are the things that I think most patients should start focusing on.
Okay, all right. So Halloween candy is probably a no. So stay out of your kids' Halloween candy.
Yes, I have to stay away from their stash.
Don't I understand? Okay, so let's start from the beginning. Coronary artery disease, that is one of the flavors of heart disease that's out there. Can you just explain to us very basically, what is that? What does that do to our body? How do we get that?
Yes. So all of us, we, when we were born, we start out with very nice, clean, pliable, very soft arteries. Blood flows very nicely through those arteries. And then starting maybe around our teenage years, that we start having these plaque buildup. And it will start out as soft cholesterol plaque. They're looking like fatty plaque against the vessel wall. Mm-hmm. And then over the years, those plaque continue to build up, and they will become calcified over time. And as the burden of plaque builds up, depending on our diet and our risk factors, it will obstruct the lumen, the inside of your vessel wall. So imagine your blood vessels in the heart and also for the rest of your body as a pipe in your garden, your water pipes or
Yeah.
in your house. And you got this calcified plaque built up over time, and it does get worse over time. And that's one of the things about hardening of the arteries as we get older, because these are building up and they're forming calcium. At some point, we can have a slow buildup and get to a very severe blockage. And you slowly one day suddenly develop some symptoms. You're walking along your normal daily walk, and suddenly you have chest pain or shortness of breath or some other unusual symptoms. That kind of prompted you to come to the doctor. And then there's another mechanism. There's someone who has maybe just 50% built up or so, but you start having some sort of stress in your system. And I think of it as if it's like a volcano, underneath your under the lining of your vessels. And when all the inflammatory factors from stress started to kind of build up, those plaque can rupture almost like a volcano again. And those are when you have an acute heart attack. When you're perfectly healthy, you can be a marathon runner, you can exercise every day at very high levels, but then you would not be able to, suddenly you have an acute episode and you would rush into the hospital. Unfortunately, a lot of patients have found that their first diagnosis of heart disease was actually when they were diagnosed with an acute heart attack. They didn't know that they have a heart problem. They didn't know that they were building up plaque. So those kinds of mechanisms, those two mechanisms are what we usually see, like a slow, steady build up to the point where it gets really tight, or an acute rupture because of certain stress, both physiologic, emotional stress,
Yeah.
or internal stress from, just diseases and such. Yeah.
Well, you're about ready to have a 13-year-old, and I have a 13-year-old. So you and I better control that emotional stress that those kiddos are going to put us under. Everybody out there that has teenagers, I know you know what I'm talking about.
I do identify.
Okay, so you explained to us what the coronary artery disease is, and how is it just the way we eat, or can this be hereditary? And how can we catch this before we have a heart attack?
Yes. So there are certain risk factors that we need to look out for. These are traditional risk factors that I think all of us may have heard about. Hypertension, high blood pressure, high cholesterol, family history, having diabetes, smoking, a very sedentary lifestyle, not active enough. Those are very traditional risk factors that we talk about. Of course, age and gender makes a difference.
Now, when you say age, well, when you say gender, see, we think of men having high cholesterol, high blood pressure. You wouldn't think of women.
Well, unfortunately, we have the same process in a way as men. It's just because our bodies are different, the hormones that we have are different. So the progression of heart disease is a little bit different in women. And on top of that, the recognition of symptoms in ourselves are different, because women traditionally always kind of take care of everyone, traditionally, always kind of doing everyone, taking care of everyone else instead of listening to their bodies sometimes. And then there's also the other part where the clinicians are not yet kind of able to recognize some of the symptoms of women because they are different. And maybe they are aware because we talk about that in medical school and in our training. But in real life practice, sometimes it's difficult. For example, I've had a very high functioning woman who is a PhD. She moved out of state now. She was a PhD in nursing. She had chest pain walking from her car to her job, to her office. And her stress test was normal, her EKG was normal, her echo was normal. Her cardiologist basically said, we did everything we can. No, there's nothing else. I don't know what those symptoms are, but they're not heart. I saw her that afternoon because her friend was a patient of mine. And listening to her story, it reliably comes on with exertion, shortness of breath, and she does have some risk factors. It's not screaming obvious, but it's there. I said, these are concerning, and if these tests, tests are not 100%. So if these tests are not accurate or are not revealing, we need to go to the gold standard, which is an angiogram. And I actually set her up for an angiogram or the heart catheterization that same afternoon. And she was found to have a 99% blockage in one of her major arteries, the widowmaker, they called it. So, she did very well afterwards. But she was really kind of shocked that, knowing she was educated, she was seeing a cardiologist, but, her symptoms were very obvious. So it's difficult. Patients have to be, we all have to be advocates for ourselves, for our family members, and, for our patients as well as a clinician.
So how come you rattled off a lot of tests that were done there? How come nothing came up on those other tests before you actually went into her heart, it sounds like, or did that catheter
Yes.
procedure?
Well, it's very, there's, these tests have a certain percentage of accuracy and sensitivity and specificity. So some tests are more accurate than others.
Okay.
And we have to keep in mind that there's nothing that's 100%.
Right.
Nothing in life is, right? So a stress test have, if you do the one that is very detailed, the one that has the nuclear pictures or with imaging as well, those ones maybe is about 80% accurate. You have that 20% where you could be wrong. I think of the heart as kind of like our house, right? So the echo, you may have heard of that. Echo is an ultrasound of the heart. Okay. That's the same as you walking through your house and looking at the doors and the windows, looking at the walls. But but it doesn't show you what your sinks are, or is there a stoppage, is there a blockage there? Yeah. So a stress test kind of gives you a sense of that, but it's not, again, 100% accurate. The EKG is to get a sense of what the electrical system is doing. Most of the time, it does show other things as well, but sometimes you have to get a specialist to go in and take a look at the plumbing itself to really diagnose the problem, because sometimes tests are not going to tell you everything.
So it makes me think that maybe your instincts need to come into play. So if some tests are showing up as this all looks okay, but something inside just doesn't feel right, to keep digging, be an advocate, like you mentioned.
Definitely. And also, as a physician, I always tell my patients, I said, even if these tests on paper are telling me that your heart looks good, but you are telling me that you're not feeling well, I'm not going to ignore that. That has to be addressed. I don't want you to be feeling these symptoms. So either we're going to look into other possibilities like GI, gastrointestinal. Can it be heartburn? Can it be a lung issue? Like developing pneumonia or something. And after that, we would look into details of the heart. But I don't want you to go home saying, oh, my tests are good. I feel really terrible, but my tests look good. That will not work for me. So that's why I said, we need to kind of look a little bit deeper and go from there.
So we have a question from one of our participants or one of our viewers, and they say, how will you know when plaque is building up in your body if you have no symptoms? And then she goes on to ask, how long does it take for plaque to cause a heart attack? What percentage of plaque can be dangerous? And then I'll read the second or the third or fourth part of this when we talk about how do you know this if you don't have any symptoms? How long does it take? And what percentage of plaque is bad?
Well, that's a very tough question. And that's why a lot of patients come finally realize or would get diagnosed with plaque and heart blockages, heart arteries blockages, when they already either had a heart attack or something had happened. So this is when we start to think about prevention. We need to know where we are, and then we lower our risk appropriately. So according to guidelines, when starting around 20 years old, we start to think about these things. You want to make sure you have your cholesterol checked. You want to make sure your blood pressure is appropriate. So at least a general checkup with your primary care physician, maybe an EKG, and then if everything, and then have a look at your risk factors. If your risk factors are in the low range, then you would say maybe a few years down the road, you repeat another kind of evaluation like that. Now, if you're higher risk, like you have a lot of family history of heart disease that occur early, or you have certain personal risk factors, the traditional ones that we talked about, but there are also other non-traditional ones. Like, for example, in women, if someone has early menses, early menstruation, or late, early, or having during pregnancy, if you have gestational diabetes, hypertension, preeclampsia during pregnancy, those kind of increase your risk actually. Or women with breast cancer going through certain, or even just in general cancer that goes through certain type of chemotherapy or radiation to the chest wall, those can increase your risk of having blockages and build up. So, it's a very personalized approach where we look at each individual, or, specifically looking at their numbers, both blood pressure, cholesterol, family history, personal history, and any kind of inflammatory diseases that they may have. Even things like arthritis, and for sure pre-diabetes or diabetes.
Let me go back with some of the stuff that you said. So let's say I'm 20 years old, right? Or I have a 20-year-old kid. That's probably more like it. Anyway, so I might want to start looking at number one, family history. Do I have grandparents, or have my parents had some kind of heart issues, a heart attack, something, shortness of breath, some kind of episode, right? And then I want to start looking. So if I definitely have some family history there, I want to look into that.
Yeah.
And then go ahead and have your cholesterol checked, your blood pressure. Those are normal. Almost every time you go into the doctor, you have the blood pressure, but you don't know your cholesterol until you do a blood test. Is that right?
That's correct. Yep.
So you're going to want to do that blood test. So at least you can get a baseline of where you're at now, maybe. Would that be helpful?
Yes.
Okay.
I think so.
So we do that. We look at our family history, then we get our cholesterol and our blood pressure. Then we start looking at our risk factors. And that's where if we have a job where we sit a lot, or it's a high stress job, And then we look at our personal habits, drinking, smoking, have teenagers. No. And then also, if you've had any complications with pregnancy, if you have any type of cancer or the inflammatory like arthritis. So you've given us kind of a really good roadmap to go ahead and look at. I have no idea. Oh, okay. Have a really good roadmap of where we can begin and start going down this path. So that's fantastic. Now, let me follow up on that question that I had asked you about the plaque, because this is very interesting. And you being a minority woman who has come here from Vietnam when you were younger, what role does bias play in the diagnosis of minority women?
Mm. Yes. So, women just in general, maybe, some, not everyone, maybe not as assertive in, in terms of kind of pursuing the diagnosis or pursuing workup. And then as a minority, sometimes it's a bit different. Maybe there's a language barrier for some. The cultural differences can make a difference. And then also, not only that, our diets and everything are different. So it will play a role, in general. But I have to say, the world is a little bit more aware of women and heart disease now. So there's still instances where it happens, and it is surprising. But hopefully that will continue to change, and people will be a little bit more, being more of an advocate for themselves and their loved ones. Now, one of your questions that you asked me earlier was, how do I know if I have any plaque buildup?
Mm-hmm.
If we don't have it, just maybe let's say you have 20% built up in the arteries of your heart, it's very difficult to see that. It's very difficult to kind of have symptoms. You may not have symptoms at all. You may be very high functioning athlete or very active person and may not know
Like that woman that you talked about earlier.
Yes. So, so you can, there are a few tests out there that are available that you could use for if you want to know. One of them is an old test. It's called coronary calcium score. It's basically a simple CAT scan of the heart that will take a look and see if there's any plaque buildup, any calcium buildup.
Okay.
The caveat, like again, as I mentioned, no test is perfect. The caveat to that test is that only if the plaque has become calcified that you can see it.
Okay.
If it's still the soft cholesterol, kind of the fatty plaque, you may not be able to identify that on the coronary calcium score. But there's a very diverse, a large group of data to say that the higher the number of the calcium score, the higher the prognosis is that you may have a higher risk of having a heart attack in the near future within 5 years or something like that. So sometimes there are patients with very strong family history, perfectly healthy, have otherwise low risk factors. They kind of wanted to know, and that's where we would suggest something like that. The next step up for that particular test would be the one that's called cardiac CT angiogram. And that's the one where you have an IV, they give you IV contrast. That's a CAT scan of the heart. It's a non-invasive where you don't need to put a catheter inside your body, but that will allow you to see actual blockages, both soft and calcified plaque.
Okay. Now, we've talked a lot about cholesterol, and one of the questions that we have is, number one, what is cholesterol? And what does cholesterol really measure? So number one, what is it? Number two, if you have a high cholesterol level, what does that really mean?
So cholesterols are these, I guess these lipoproteins. These are things that are floating around in your body, both by your liver producing it, that's a natural process, as well as the food, the amount that you take in. So when you check your cholesterol with your doctor, it's usually as part of a panel where it will be broken down into total cholesterol, the amount of the good cholesterol, the HDL, or the bad cholesterol, or the LDL, or also the bad one is the triglycerides.
Oh, right, right.
So yeah, so these are the typical ones that we see in the cholesterol panel. And I know, usually the good cholesterol, the HDL, that's the one that generally is considered protective of the heart. So they are good in the sense that they don't increase your risk of plaque buildup or having a heart attack. But the LDL and the triglycerides increases that issue. It increases the risk of plaque buildup. So you measure that, and they have different guideline recommendations depending on your personal risk factors.
Okay.
So
They look at your level of total cholesterol, and then the HDL and the
a
LDL,
breakdown. Yep.
and then they also look at the risk factors.
Correct. The risk factors will determine what your acceptable range for the bad cholesterol would be.
Okay, all right.
So
Now, you were talking to us about the test. There was the coronary calcium score, the cardio, or the
the
cardiac
cardiac
CT.
CT angiogram.
Yes. Now, one of our viewers brought up, what is your view on Lifeline screening? Now, the Lifeline screening isn't covered by insurance, but this viewer states it evaluates inflammation and blockage in your body. Is that correct?
Well, Lifeline screening, as I know, is the one that usually they do it in one of those mobile units. And that will include a basic EKG, an echo, testing for the vasculature to see if you have any hardening of the vasculature, carotid ultrasound, and basic cholesterol check. So I think these are reasonable in someone who sometimes we cannot order, they are very concerned about, for example, carotid blockage because they have it in their family, but the insurance company does not cover because their neck arteries sound fine. They don't have any sound or unusual,
They don't have any symptoms.
yeah, no
to
symptoms, no
justify
stroke, nothing.
insurance.
So I think I have mentioned this to a lot of my patients who are kind of in the lower risk range, but they are interested to know kind of an overall sense of where their well-being is. So then they would bring to me the results, and I'll go through the result with them. I would tell them, okay, these look good, or these may require a little bit more in-depth look.
Okay.
So it is useful in that sense in certain groups of patients where, they don't have a lot of symptoms, but they're concerned and they want to know.
Okay, that's an excellent point. It sounds like if you're able to do that and you have some concerns, it's probably worthwhile if you can pay for it and put your mind at rest a little bit, and then have something to talk to your doctor about.
Yep, that's just a baseline. Yep.
Okay, very good. Baselines are good. Baselines are good because then we get an idea of if we go up, great. If we go down, you know what I mean. Okay, so we were talking about minority women and the diagnosis and possible bias. Here's another question that follows up on that. This viewer states that social determinants play a significant role in health diagnosis for women, but stereotypes still have an impact on how minority women are treated. Do you have any thoughts on the systematic racism in heart health care for minority women? Do you see that a lot? And if so, what can patients do, or what can we do as advocates to help with that?
Yes, so um, sometimes one of the major issues is access to care.
Mhm.
So, depends on the social, economic levels, or, lack of insurance,
Mhm.
or, or sometimes women being the main caregiver of the family, that they don't even have time to go to see the doctor. We sometimes see patients presenting very late in their stage. When I was in training in Chicago, we saw a lot of women. Part of our training at Rush University was also at Cook County. We saw a lot, not just women, I have to say, but um, uh, there are men as well. But some of the women came in with mitral valve disease that we don't even see anymore in our country. We see it in others. Or there are patients who come as an immigrant and have not really been aware of these issues, and then they are not able to come to see the doctor for those reasons. So they present later. So the morbidities, not just death, etc., but the morbidities of having untreated heart disease leading to congestive heart failure is probably higher in those patients than not.
All right, so we've talked about what heart disease is, or at least one of the types of heart disease. We've talked about things that you can do to start diagnosis or to start getting a baseline, or if you're concerned about it, what you can talk to your doctor about and some things that you can do. We've talked about some of the bias that's in the system dealing with women, minority women, and the reasons why that exists there. Let's talk a little bit about, what do you do when you realize my cholesterol's high, I have these significant risk factors, or I have a lot of plaque buildup. This isn't the kind of plaque where we go to the dentist, right? Or we buy certain toothpaste or anything like this. This is very different, and most of us don't know what we can do other than maybe stop eating butter, right? So we've now found out that we have some problems here. We haven't had a heart attack, but we realize we've got some problems. So what are some steps that you talk to your patients about, just in general, that you can do or start looking at?
So when we start to identify certain risk factors in ourselves, then usually we have to be really proactive about that. And prevention, as you mentioned, they haven't had symptoms yet, so it's still prevention.
Mhm.
So naturally all of us will build up plaque. If you're have a terrible diet and lifestyle versus someone who's really healthy, we all will eventually build up plaque. The difference would be the progression and how fast you build up. So it could be the difference of someone having a heart attack in their 50s as opposed to in their 80s. Or people who would have a more active lifestyle and be able to enjoy more and have better quality of life than at their 80s, rather than dealing with all these issues when they're in a younger age. So prevention is always the first step. All the traditional risk factors, some are definitely modifiable. So those are the things that you want to make sure you get really aggressive on. So usually we would give time. We don't always start with medications. For me, at least, we talked about lifestyle and changes to your diet and your exercise, your stress level. I've had patients where their job are extremely stressful to the point where that their blood pressure is through the roof.
Yeah.
And I've had one patient where, you know, after we've tried and talked and done a lot of different things, one of the final things that he had or that patient had done was basically kind of reducing some of the responsibilities at work, and
Mm.
the blood pressure became miraculously in place. So I think, you know, a lot of these issues are modifiable. And then of course, unfortunately, age and gender are not easily changed. So, uh, and you know, we do see that sometimes. You know, transgender patients sometimes do have the same risk factors as the original, the original sex.
Right.
So it's those are difficult to modify. And then of course family history are difficult to modify. So that's when, you know, you try to do what you can and then work with what you have.
Yeah, you know
So
what? That's an excellent point. We can't, it's that old adage, you can't change what you can't change, right? So don't focus on the things that have happened in the past or those things that you simply can't change.
mm,
Gender, the vast majority of people are not going to change their gender. They can't change who their parents or their grandparents are, right? They can't change how their body developed up until this point, right? But we should focus on what we can control, right? Which is
yeah,
the diet and the exercise.
yeah,
And if you're joining us, we've been talking about heart disease and how it is the #1 killer of women. And it still blows my mind, even though I've known that for the past couple of years. It is still very surprising because we don't expect that. Now, are there certain minorities or certain groups of women that heart disease impacts more biologically, like they just have they're more likely to get it than another one?
not that I in terms of race
Mhm.
I don't think I can say that for sure.
Mhm.
I know that there's a certain, East Indian men, this is not women,
Okay.
who have sometimes higher heart attack issues, even though they are vegetarian in diet. And some of that partly because in the arteries of their heart are formed a little bit smaller size
Hmm.
than what we normally see. So sometimes some plaque buildup may make a bigger impact in a smaller vessel. So, um, and then among American Indians, sometimes what we see is because of the prevalence of diabetes in American Indians, that can be a major risk factors. Kidney problems, a large majority of, or not large, but there's a sizable amount of American Indian women and men as well
Right.
with both diabetes and kidney problems. And those are two of the major contributor to inflammation overall, which would lead to plaque buildup. Um, and then I think in general, Asians, we're talking about like Asian, like Southeast Asians, like Vietnamese, Japanese, Chinese. Um, it's not dramatically more than other that I have seen. Um, I have to say though that sometimes these Southeast Asians are not going to the doctors as often because they're feeling well and they're not out there to be like, I want prevention.
Right.
Sometimes they may not realize it. Maybe it's just a culture. It's a little bit different in that sense. Um,
One of our viewers pointed out that according to the AHA, African American women have the highest risk of death from cardiovascular disease. I think that's what CV means. and cardiovascular disease, I think so. And could that be also because of socioeconomic concerns, the bias that might be out there, and maybe culturally, are there some groups that don't go to the doctor, or they're more, and setting aside access, but you had talked about cultural factors before, that there are some cultures that maybe it's not okay to go to the doctor, or it's just not the norm.
Yeah, maybe they're not, it's not the norm for prevention, for them.
Okay.
And the prevalence of hypertension in African American is quite high, and sometimes it's undiagnosed, and sometimes they start as young as in their teenage years to have hypertension. So I think, if you feel well, sometimes they said, "Oh, I feel fine, so maybe I'm okay." I
Mhm.
think that's when, I think part of the guidelines is that starting in your 20s, you should start kind of paying attention to these things, having blood work, having, basic checks, just so you can kind of head off any problems if you see them. Pre-diabetes is a major concern, with um, Hispanics, women, African American women as well. Pre-diabetes is a big concern. For a long time, it's not treated, so um, uh, and we know that it will continue to cause inflammation and lead to plaque buildup more than other conditions, actually.
Okay. Let me go through just kind of a recap of everything that we've talked about the past 51 minutes or so. This is just such great information. And you bring it to a level that we can understand. And I know that I appreciate that, because I am not a doctor, right? And so I'm learning just like everybody else. So if we start with, we talked about, okay, first, hypertension is high blood pressure, right?
That's correct.
Okay, all right, just making sure I got that right. So if you have a family history of hypertension or heart disease, if you've had complications during pregnancy, if you're diabetic or pre-diabetic, you have a sedentary lifestyle, you're a drinker, you're a smoker, these are the things that you need to, if you do any of these, if you're in that circle, right, you want to start talking to your doctor about heart disease. Did I get that right?
That's correct.
And who do you start with? Do you start with your family physician first?
Yes, that's usually a good start. Sometimes patients need a referral to see a specialist.
Mhm.
So sometimes you don't need to always start right away. Just, for some women, actually, it's your GYN, your OB/GYN.
Yeah.
So, some basic blood work with your OB/GYN or your primary care physician. And then they may not do an EKG. So we'll see, depends on how worried you are or what your risk factors are. You can do a little bit more and go and see a specialist, see a cardiologist at that
And
time.
you can always look into that lifeline screening, which is basically kind of a baseline, all kinds of different screens of your body to see if there's blockages or problems somewhere. You mentioned that could be a good start.
That can be kind of a overall look to begin with. Yeah.
And then I especially like that you brought up, of course, preventative, right? Make sure you exercise, watch your diet. And you brought up that the Mediterranean diet is the most effective, or it is presumed to be the most effective when it comes to dealing with heart disease.
Yes, mainly because of the anti-inflammatory effect of the diet itself. So I know for each of us, the cultures are different. The way we cook our foods are different. You can still use the same spices in your diet, probably, and but maybe the basic is more fresh fruits, vegetables, more omega-3 like fish and nuts. Yeah.
All right, very good. Now we're almost out of time, but I want you to have the opportunity to talk about this slide and the information that's on this slide.
Yes. So I am part of a group called Tri-City Cardiology, and we basically have about 24 board certified physicians. We do a full range of everything that deals with cardiovascular disease. Either is the clinical cardiology, that what we basically had talked about, but also arrhythmias, that's electrophysiology. We also put in stents, we do pacemakers. We also have a vein clinic where we deal with vascular disease in the legs, peripheral vascular disease. We serve mainly in the East Valley, and you can see our locations there. And we do a lot of our testing in the office, as well as our surgery center and our vein centers.
Okay, so this sounds like an amazing place. If you have some concerns, if you've got some family history, go ahead and give that number a call. Come in and talk to you, since you've been so wonderful, and you say you're all about honesty and good communication with the family and the patient, so everybody understands. Go ahead and visit tricitycardiology.com, or do the old-fashioned thing and just pick up the phone and call. One more question came in, and I find this interesting because I often wonder this too. Are some nuts better than others? Versus like coconut oil, or what's a good oil to cook with when you talk about the Mediterranean diet and the plaque buildup?
Yes. So, I know a little bit about some of the diet things, but I'm not the expert. But I know that certain nuts are better. I think almonds are better, I think, than cashews and peanuts. They're a little bit more anti-inflammatory with the almonds and walnuts. In terms of the different kinds of fats and oils, we've had patients who had increased in their LDL, the bad cholesterol, with the coconut butter or the coconut oil. Yes. Yeah. So coconut water, I think, is okay. That's refreshing and it's low calorie. But the coconut milk, butter, or oil, I find that to be a little bit high in the bad fats. And I know it's kind of part of the keto diet, right? Do people use that a lot in the keto diet?
I think so, yeah.
Yeah.
Coconut has had its day.
But olive oil, I think the vegetable oils are what we're talking about in terms of the traditional, more Mediterranean, more anti-inflammatory.
Well, you may not be an expert with cooking, but you are an expert in so many areas, and with so much of the information you've given us. I mean, I have a whole thing of notes here, but I am so grateful that you could join us today. Dr. Camille, let me say this right, Phuc. Thank you so much for joining us. I mean, you have been just a shining star in giving us this information. For our viewers out there, please share this webinar. This is great information for everybody, not just women, but for men. For the 20-somethings that are out there, go ahead and share this information. If you're interested in becoming more involved with Arizona Foundation for Women, please visit azfw.org. You can also find the board of directors. A lot of us are on LinkedIn. You can find AFW on Facebook, Twitter, and Instagram. Most of our information comes out on Facebook, just to let you know. But Doctor, I want to go ahead and give you the last say. So in the last minute, what if we could only take one thing away from this webinar and remember, what would that be?
Well, first of all, I'd like to thank you for having me here. It's an honor. Among women, I think we have to really look out for each other.
Mhm.
and yourself and your loved ones, whether it's heart disease, whether it's cancer, whether it's just simple everyday life stress. We
Mhm.
have to stick together and be advocates of each other. So I think that's our basic message for this world nowadays.
I think that is a great message. There are enough crowns to go around. We don't need to try to steal them from each other, right? And to have each other's back.
Yeah.
So, Doctor, thank you so much for joining us. And like I said, you can go ahead and watch this webinar again. And any information, or any questions, go to azfw.org. And thank you so much for joining us today. Bye,
Thank you
everyone.
very much. Bye bye.